great pleasure to be here today. I've only got about 10 minutes to tell you about this data, but I'll try and keep it as succinct as possible. And absolutely, I'll be round, so if you have any burning questions or you want to know more about general practice research, which unfortunately I know quite a lot about, I'd love to share with anybody, especially anybody who is interested in starting to work with our department at Melbourne University and elsewhere on any projects that we can help you with. So without further ado, I am a fellow, an Aurora Fellow, whatever that means, at the Polar Institute, as we call it, and we were asked by you guys to find some data about melanomas and other skin cancers in primary care. So we are delighted to start off with what does it all mean? The population level analysis and reporting tool, which is the POLAR tool, everything has to be acronyms, supports quality assurance initiatives in general practice, much like our beloved NPS, which has just been defunded, unfortunately, so things are changing in this space. The Aurora platform facilitates general practice research, which is a very, very cool piece of technology that you can look at different cohorts in your own practice or in bigger groups if you want to. So it's pretty interesting stuff. So this report was produced looking at 3 of the 7 different populations that we look at. So very briefly, primary health networks work in partnership with Polar, and the primary health networks gather information from general practices. It's part of the electronic PIP process. We have to give data to the networks. And Polar is one of the data collection mechanisms for the PHN. So we work cooperatively with the PHNs. So this one is East Melbourne PHN, Gippsland's PHN, and South East Melbourne PHN, which are, I don't know, you know all the PHNs, I'm sure some of you do and some of you don't. We work with 7 different PHNs and we have about 1,300 practices worth of data. So that's about a quarter of the data in Australia. So there's about 7,500 general practices. So, and we're growing, which is good. Clicking it along, we have 314 practices from the East Melbourne PHN, 57 from Gippsland and 182 for this report from South East Melbourne PHN. As you can see from the circle, we start with about 9.5 million electronic records, and then the machine grinds them down to figure out who are regular patients. So we call the RACGP regular patients, which is 3 visits every 2 years. And then we try and rule out people who are the same person going to different practices. So at the end, when we look at this data, we can get down to 2.3 million unique RACGP active patients for this report. So Polar reproduces a longitudinal view of patient records. The data is de-identified at the point of collection. So we don't know who the people are because we don't want to be able to identify them, which is normal practice. Data is deduplicated, as I said, with privacy protection linkage keys, so we can make it much more usable data. And then the diagnosis data is coded according to SNOMED. And I don't know if you've heard of SNOMED, but that's Systematic Nomenclature of Medicine Standards. So, looking at our cohort summary, as I said, we have 2.5 million files, and then once we statistic linkage keys, or how we clean up the data, we get down to about 2,300,000 files. So what this report can tell us is it gives us indication data for number of skin examinations, indicative data for skin cancer diagnosis. We can use MBS codes to see how many skin biopsies have been done in general practice, the number of excisions of skin lesions in general practice, and also we can get some indicative data for referral patterns for patients coded with melanoma to people like you. What this report doesn't tell us is it doesn't really tell us the results of what's found in general practice, and we can't really see what the referral process is. We get some ideas, but most of that data is written in the progress notes on GP data. I don't know how many of you people ever worked on any of the computers in general practice. We were really the beginning of computerisation in medicine in Australia, but most of the data is written in progress notes, and it's very hard to interrogate because we're not really allowed to look there. That's considered private. Sometimes there's things there that people mightn't want to know. So we rely on the GPs actually coding the diagnosis or the reason for visit and some other data in order for us to make some meaningful conclusions from that data. So GPs are getting better at using the computer systems for collection of data, but a lot of GPs don't do much research. They don't really see the value in coding diagnosis, but we're working on it. Also, it doesn't really tell us the outcomes of biopsies and things like that, because unfortunately they come as PDFs into the file and we can't really use the data, or we can't really use the tool to be able to figure that out very clearly. And also we can't also tell about recurrence rates post-excision. But let's see what we got in the data to share with you. So this one is diagnosis of skin examinations, and when we talked about this data last time, I think you'll all agree that if you look at the little orange line, which is the Gippsland network, during the pandemic there was a big drop-off in the number of people going along for skin checks. So it's come up a little bit in 2021, and hopefully the data will show this year that it's come back to what seems to be the normal before, which was about 1,800 on the data. So that shows the pandemic may produce more melanomas and other skin cancers from people who haven't presented yet. The next one was biopsies, and you can see again the same pattern. In the cities, in the East Melbourne PHN and South East Melbourne PHN, people were going along to the doctors for skin biopsies, but again over in Gippsland there was a big drop. And you can see that presented there in the differences. Then we look at the actual skin cancers themselves. Basal cell carcinomas, melanomas, it certainly seems that if they're there, there wasn't a drop-off. So in Gippsland, if somebody had a nasty basal cell carcinoma, they were going along to see the GP. Melanomas seems to be the same. That's just an idea. Squamous cell carcinomas as well. So we also had a little look at malignant skin excisions. As you can see, that's that data. And this is all, as I said, based on MBS codes. Referral profiles. Interestingly, looking at the data that we saw before about the drop-off, the referrals didn't seem to drop off. They seem to be pretty consistent during the time. And similarly with general surgery. So they're the two different groups that we could pick up from the data where people were going, and the oncology. Plastic surgeons. So again, year on year we saw a slight drop. So the conclusions, data collected during general practice encounters is complex. So, it's not as straightforward as you'd think. The report was generated using both SNOMED codes, which relies on GP's data entry but is well structured, and MBS billing codes, which unfortunately, when you go out of general practice software, the only button you can't, or the only part you can't get away from is billing. So you don't have to put a diagnosis in, you don't have to do even notes, but you can't get out with charging the patient. This report was intended as a taster for what's available and possible with GP data. Unfortunately, we didn't get a large amount of money to do this report, so it's, as you can see, it's not as deep as we'd like, but we'd like to work more with you in the future.